Trying to get pregnant at age 40 and older. Hi friends, I am Dr. Natalie Crawford. I am a board-certified OBGYN and REI. I'm a fertility doctor. And today, the day this video is getting released, it's my birthday. So happy birthday to me. I am turning 40, so I think it's super timely to talk about what if you are trying to start your family or grow your family and you are 40 and older? What do I want you to know? First of all, this channel exists to spread knowledge about your body and your fertility. Please subscribe if you want to learn more. Can women get pregnant at age 40 and more? Absolutely, they definitely can. Do you have a lower chance of getting pregnant per month? Also, yes. I think it's very important in this circumstance to realize that your time is your most valuable commodity and you want to be educated so that you are using your time wisely. The chromosomes inside a normal egg are 46XX. Inside the egg, I want you to imagine that the chromosomes are lined up in the middle and held apart by these little meiotic spindles of proteins. When you ovulate, part of the job is to separate these chromosomes apart. Half of them go into a polar body, which is considered trash, and half of them are in the oocyte or the egg that can be fertilized. This is the half of the genetics that's coming from the maternal side. However, as we get older, these chromosomes start to split abnormally at an increased prevalence. This is largely because the proteins of those meiotic spindles start breaking down. Our eggs take on the wear and tear of our life, and over time, things are just going to disintegrate. And there's very little you can do about it, although there is some, and we will review that at the end. So the first thing we want to know is just in a natural fertility cohort, what happens when women who are older start trying to conceive? There was a fabulous study done by one of my fellowship mentors, and I did a ton of research in this cohort. The cohort was called Time to Conceive. It was a large population-based cohort in North Carolina. And this study is called The Impact of Female Age and Nullogravity on Fecundity in an Older Reproductive Age Cohort. This cohort followed people who'd been trying to get pregnant for less than or equal to 3 months and watched their cycle pattern history, tracking ovulation, and just reported a pregnancy. There was no intervention beyond just cycle tracking. Everybody in the study was age 30 and older. So the comparison group is people who were in their early 30s, not people who are younger than 30. There were 960 people who were in the study with over 3,593 cycles for evaluation. For women who were under 38, the average time to pregnancy was 3 months. For people who were 40 to 41, the average time to pregnancy was 8 months. And for people who were 42 and older, the average time to pregnancy was greater than 12 months. Compared to the reference group who was under age 34, women who were 40 to 41 had a 53% reduction in chance of pregnancy per month, and women who were 42 to 44 had a 59% reduction per month. When we broke this down in a little bit different way to look at it, what was your chance of getting pregnant in 1 month? What was your chance per month overall? And what percentage of people got pregnant? In the age group 40 to 41, 6.2% of people got pregnant in the first cycle trying. After 12 cycles, 54% of the age group was pregnant, with a monthly chance of being pregnant of 8.6%. However, in the age group of 42 to 44, what we saw is that no people got pregnant in the first cycle. Overall, though, at 12 months, 48% were pregnant, and the average chance per pregnancy was 6.6 per month. Can people 40 and older get pregnant? Absolutely. In this study, almost 50% of people who were trying to get pregnant did get pregnant, and this is of people who just first started trying to get pregnant, trying for approximately a year. Now, if you compare that to the younger age groups in the same study, people who were 35 and younger, 80 to 90% of them were pregnant at a year. So you can see there's a much higher chance of infertility as you got older. However, where this data becomes really important is stratifying by people who've been pregnant in the past versus people who've never been pregnant. So people who had never been pregnant, who were 40 to 41, had a 2.9% chance of pregnancy per month and an overall cumulative chance of pregnancy by the end of 12 months of 25%. If you compare that exact same group, so age 40 to 41, who'd had history of a prior pregnancy, their chance of being pregnant per month was 9.8%, and their overall cumulative chance of being pregnant was 56% by the end of 12 months. So there's a huge difference in the people who've never had a pregnancy before. And so this should be number one, the first thing that you're looking at if you're starting to try to get pregnant at age 40 is, have you achieved success in the past? Are you trying to add to your family, or is this your first attempt at having a family? To support the fact that this change that we're seeing is due to abnormal chromosome number, there was a great study published in Fertility and Sterility also that is effects of maternal age on euploidy rates in large cohort of embryos analyzed with 24 chromosome single nucleotide polymorphism-based pre-implantation genetic screening. Essentially, in this study, what they did is they did PGS, or screening of embryos prior to implantation, to look at the percentage that was euploid across different ages. This graph is showing us right here, but there's a steady decrease in the percentage of euploid embryos after age 35. And at age 40, the approximation of normal embryos is around 25 to 30%, dropping significantly as you get older than that to be around 10% at age 44 to 45. Okay, so this data is scary, and as somebody who is in this age range, it is actually scary. This is what advanced maternal age is. So being age 35 and older is considered advanced maternal age solely because you have an increased prevalence of chromosome abnormality. This previously, before we could test embryos or do any of this stuff, this would be detected on your prenatal screening once you were pregnant. Screening tests for Down syndrome, trisomies 13 and 18, those are some of the more common chromosome abnormalities that can be detected in babies. Now, a lot of these chromosome abnormalities do not fertilize, implant, and that's why we're seeing lower pregnancy rates in this group, right? If all of these chromosome abnormalities led to becoming babies, we would see this consistent pregnancy rate. We would just see a huge drop off afterwards. So the fact that we're seeing a lower chance of pregnancy overall is telling us that this is the number one reason why. So what are you going to do with this information? Number one, you're going to expedite a workup. Number two, you're going to do everything you can to impact your egg quality the best possible. And number three, you're going to make most of your months trying to conceive. I always tell my patients who are older that there's no reason for us to suddenly just start seeing what happens. If it happens, it happens. If it doesn't, it doesn't. We need to take a more proactive approach so that we can have the family that we want to have. Number one, your history. If you've ever been pregnant in the past, you overall have a higher chance of getting pregnant right now. So that should be a reassuring sign. If you have never been pregnant, you need to be paying close attention to your cycles and get an evaluation sooner. Honestly, I tell everybody, if you're 40 and you're starting your family, I would love to see you at the very beginning. Do a basic fertility evaluation. If it's all normal, we might choose to let you go try to get pregnant naturally for a period of time. However, if it's abnormal, then you have not wasted your time, because the sooner we get moving on treatments, the higher chance of success we're going to have. So what do I mean by that? Number one, is your period pattern regular? Are your periods coming at regular, predictable intervals? If they are, great. If they are not, go see a reproductive endocrinologist for the beginning. We want to check to see, are your fallopian tubes open? Do you have any history of prior abdominal surgery, history of infections like gonorrhea or chlamydia, history of endometriosis or suspicion of that? In those circumstances, there's a higher pretest probability that you might have a blocked fallopian tube. Either way, you need to have open tubes and a normal uterus. Any history of uterine fibroids or polyps, intrauterine surgery, or medical terminations, those are other reasons why we would want to look inside the uterus. So anatomy, looking at the inside of the uterus and the fallopian tubes, this can usually either be done with an HSG test, which is a hysterosalpingogram, a dye test where we put dye into the uterus to look at the uterus and the fallopian tubes, a test called a FemView, also known as the bubble test. It's a combination of a saline ultrasound and then pushing air and water bubbles through the fallopian tubes, or even going to surgery with a laparoscopy and hysteroscopy, camera in the belly button and camera in the uterus. It's obviously a much more invasive approach and not currently recommended for diagnostic testing anymore. The next thing is a semen analysis. So checking sperm. If you've got a partner with sperm, we want to make sure there's good volume of the sample, the concentration is normal, the sperm is moving well, and of normal shapes. Abnormalities in these parameters can impact our pregnancy rates. So if somebody who is older comes to me, that's the basic fertility testing, getting a good period tracking history, checking anatomy, checking sperm counts. The other factor that we like to consider is checking your ovarian reserve. Please note, I'm only talking about your reproductive chances per month. I didn't mention one time running out of eggs. Everybody does run out of eggs. And my favorite analogy is to imagine that you have a vault inside your ovary, and that's where all your eggs are kept. When you're born, the vault is full, and throughout your life, eggs come out of the vault. And when the vault is empty, you're in menopause. The number of eggs decrease in the vault over time, and when the vault is less full, fewer eggs come out. When the vault is more full, more eggs come out. On a month-to-month basis, when you're trying naturally, that doesn't matter, because the number of eggs outside the vault is only important in understanding our timeline or if we're doing IVF. The number of eggs outside the vault is just how many die. So if you have 12 eggs outside the vault or 4, in both circumstances, the body's going to want 1 egg to ovulate. The difference is, are you having 11 eggs or 3 that are dying off that month? AMH is a blood test. Essentially, it's a hormone that is made from the cells surrounding all of the eggs that are outside the vault. So when you have more eggs in the vault, more come out, higher AMH. Fewer eggs in the vault, fewer come out, lower AMH. Lower AMH values are not reflective of abnormal fecundability or chance of getting pregnant naturally. However, it's putting a fire under our feet because we have less time to achieve our goals. If we want to have more than one kid, super important now because we need to be pregnant in the future, and is changing our IVF outcomes on a cycle basis, meaning those with a lower AMH often will need more cycles to get to the same outcome as somebody who has a higher AMH. Therefore, you want to get started on those cycles faster before your AMH is even lower, because those eggs outside the vault, the eggs that you can get in an IVF cycle. So one person can get 12 eggs in one cycle, one person could get 4. They could have the same outcome, but this person needs to get 4 eggs from 1 month, 4 eggs from the next month, 4 eggs from the third month in order to have the same egg number as a peer. So this is part of understanding the strategy and the urgency for the timeline. So that is going to be ovarian reserve. One of the biggest advantages to considering IVF in a patient group that is older is that you can test the chromosomes of the embryos before you implant them inside, and you can get a higher live birth rate per transfer than if you don't. So when you look at IVF statistics, you have to understand, is that a euploid or a genetically normal embryo that underwent genetic testing, or is this an embryo that hasn't had genetic testing? When you transfer a euploid embryo, you have the same chance of pregnancy, which is about 65 to 70% chance of live birth, versus if you're looking at just IVF outcomes overall using untested embryos. So one of the advantages in an older group of going to IVF is you can get a higher efficiency to pregnancy and get pregnant faster, because we're ruling out that number one thing that's sitting in your way. Also, if you're 40 or older and you're just starting your family because you met your person later or you were chasing some amazing career dreams, that's great too, but we can give you the highest chance of having the family of your dreams by doing what we call embryo banking. Embryo banking means that you purposefully get embryos to save for a future pregnancy. Typically in the math equation, we like to have 2 embryos in the bank for a future pregnancy. So if you told me you wanted 2 kids and you were 41, I'd want to make sure we have at least 4 embryos before we start transferring. So you might go through multiple months of cycles, getting eggs from 1 month and then the next, in order to get to that goal, so that we don't see that drop in pregnancy as time goes on, or the fact that it might take you a year to get pregnant naturally, and only 25 to 50% of patients in that age range will actually achieve a pregnancy in that timeline. What have you lost in that time? And at what point are you no longer going to be able to get pregnant because all your eggs, or the vast majority, are genetically abnormal? All of that said, let's pretend we check everything comes out okay, you want to try to get pregnant naturally. We want to be as efficient as possible in getting pregnant, so tracking your cycles is going to be key. Studies have shown, including a study that I did, looking at tracking your cycles, whether you use the calendar method, whether you use basal body temperature, cervical mucus monitoring, or ovulation predictor kits. They were all better than nothing. So using one of these methods of fertility awareness and cycle tracking was excellent. I personally like OPKs a lot, and I have a whole video on it because I think they're pretty straightforward. They are measuring LH, which is a hormone secreted from the brain that triggers the body to ovulate. Some keys in using OPKs is you typically want to start them around 5 or 6 days before you anticipate ovulating. So for most people in an average cycle length, this is going to be around cycle day 9. I recommend using an ovulation predictor kit 1 time per day in the middle of the day, sometime between 10 a.m. to 2 p.m. So don't listen to what the box says. This is because we're checking luteinizing hormone in the urine. It's secreted from the brain in the early morning. It's got to get through your kidneys and be in your urine so we can check it. The day you get a positive is the day before you ovulate. So you'd like to have intercourse on that day and the next. Don't keep checking OPKs afterward, because LH then fluctuates throughout the entire luteal phase as it stimulates the corpus luteum to make progesterone in pulsatile fashion, and so it'll drive you bonkers. Save your money in case you're not pregnant and use those OPKs in the next month. We also want to set you up for success. So everything you can do to optimize your natural fertility is going to be the best. So you want to track your cycles, you want to time your intercourse, you want to avoid lubrication if possible. If needed, then fertility-based lubricants like pre-seed or water-based are going to be preferable. You want to decrease stress. I know that's easier said than done. We got to think about the whole body and lifestyle factors. So take care of yourself. I want you to be taking a prenatal vitamin with at least 400 micrograms of folic acid for 3 months before you want to start trying to get pregnant. I'm recommending that my patients who are older also take an extra vitamin D supplement of around 2,000 IUs a day. I check vitamin D levels, so some people need a little bit more, so ask your doctor. I also like coenzyme Q10. CoQ10 has been shown in some studies to increase the stability inside the oocytes. The dose of CoQ10 that I like is 200 milligrams 3 times a day. That way we can support those eggs with everything we need. And I also recommend fatty acids. So omega-3 fatty acids, those beneficial fatty acids, really important in cell division and creation. Those may be in your prenatal, or you may need to take a separate pill depending on your prenatal brand. I get asked all the time, which prenatal? The one that you take is going to be the best. So what I say is look at those things I just said. If you can find one that has those things in them, fantastic. If not, you can piece it together. But there's not one prenatal that's truly better than the other ones. Find one you can tolerate, that doesn't make you too nauseous, and that you can reliably stick to and take, which is the most important thing. Optimizing your diet and your overall health is going to be really important. So take this on seriously. You want to avoid toxins in your life. I recommend you stop smoking. Cigarettes and marijuana, both male and female, can impact sperm and egg health and quality. Look at environmental toxins like BPA and other factors, reduce those from your environment. Have a diet that's full of fertility-friendly foods like fruits, vegetables, whole grains, healthy fats, and you want to limit out processed foods, sugars, red meat. Exercise is going to be good for you, so make sure you're getting out and you're moving your body. It's a great way for stress relief. If you're undergoing fertility treatments, ask your doctor specifics about vitamin supplements or exercise restrictions, because depending on what you're doing, your doctor may say something different. The take-home message I hope you hear is that women over 40 can absolutely get pregnant, but time is of the essence. The last thing I want you to do is waste a month of your life trying to get pregnant while your egg quality is decreasing over time. We also know that the miscarriage rate increases as you get older for the same reason, these chromosome abnormalities. So if you're getting pregnant but you're miscarrying, please go see your doctor. We recommend evaluation after 2 losses. Although age is the #1 cause for those of us who are older, there also can be other causes of recurrent pregnancy loss, such as inherited chromosome abnormalities, autoimmune thyroid disease, diabetes, clotting disorders, and anatomical factors. So if you're suffering from pregnancy losses, please go seek help. I hope you understand that your reproductive community of REIs, we're here for you. If you are starting your family at an older age, I want what's best for you. The #1 thing is to understand your goal. What is your goal? What is your goal now and in the future? What does your whole family look like? Find an REI who you can trust and be honest with, and go get an evaluation early. The last thing you want to feel like is looking in the rearview mirror and wishing you hadn't wasted time or that you made a different choice. If you know the information, you can make an educated decision. But can you get pregnant over 40? Absolutely. Might you need help? Potentially. But I don't want you to feel like all hope is lost, which I see so often from so many people. As always, thank you so much, friends. I love your support. As a birthday present, subscribe to the channel if you don't. That would just bring me so much happiness. You can always follow along on Instagram at Natalie Crawford MD, and listen to the As a Woman podcast for more fertility-related information. Bye, friends.